Welcome to the Deep Dive. Today we're taking a fascinating look beneath the surface, literally, with venous duplex scanning.
That's right.
Think of it as a specialized ultrasound that gives doctors a really detailed picture of what's happening inside your veins,
Yeah.
beyond just what they can see from the outside.
Exactly. And we're going to explore the ins and outs of this technology today.
Yeah.
We're drawing our insights from Rutherford's vascular surgery and endovascular therapy, specifically the chapter focusing on vascular laboratory venous duplex scanning.
Right. And our goal for you today is really to gain a solid, efficient understanding of this venous duplex scanning.
hmm
We want you to know why it's used, how it actually works, and why it's so important for diagnosing and managing various vein issues.
And the key is, without getting too bogged down.
Exactly. Not overwhelmed with super technical details,
Yeah.
ready to explore this essential diagnostic tool.
Absolutely. Let's dive in. So let's begin with the fundamental question. What exactly is venous duplex scanning?
Okay, let's unpack this.
Yeah.
Our source tells us it's readily available, it's non-invasive,
Right.
and relatively inexpensive.
Yeah.
It's a primary means for diagnosing two key conditions:
Okay. Which are?
deep vein thrombosis, DVT, those potentially serious blood clots in the deep veins,
Yeah.
and also chronic venous insufficiency, or CVI. That's more about longer-term problems with blood flow in the veins.
That's right. It's really the main first-line tool for those diagnoses.
hmm
Now, what's really insightful here, I think, is that while it's powerful technology, its accuracy really depends quite a bit on the skill of the technologist.
The person actually doing the scan.
Yeah. And also the expertise of the doctor interpreting those results.
Oh, right.
So, standardized training and accreditation are just vital for you to get a reliable diagnosis from this.
That makes perfect sense. I mean, the best tool still needs a skilled hand, right?
Exactly.
Now, this technology didn't just appear overnight, did it? What's the story behind it?
Well, this is where it gets really interesting. The early steps, they were taken back in the 1960s.
Oh, yeah.
That's when they first started using Doppler ultrasound just to examine veins in the lower legs.
Just listening, basically.
Pretty much. But our source specifically highlights the work of David Sumner, Dennis Baker, and D. Eugene Strandness in 1968.
Right.
They were among the pioneers who figured out how to use an ultrasonic flow detector to really understand the patterns of blood flow within veins.
So listening to your veins with sound waves, that's quite something for back then.
It really was. And then a few years later, in 1972, Strandness and Sumner built on this.
Okay.
They published their findings on using this Doppler ultrasound technology to actually diagnose venous thrombosis, a blood clot.
Wow. So just listening to the flow gave them diagnostic information?
To a degree, yes. But then came another key development. In 1982, Stephen Talbot published his work on using B-mode imaging.
B mode, that's the picture, right? The grayscale image.
Exactly. The two-dimensional grayscale image you typically see in ultrasounds, he used that for diagnosing DVT. So this gave doctors an actual picture of the veins themselves. We moved from just hearing the flow to, also seeing the structure.
Okay, so visual confirmation. That sounds like a huge leap forward.
It was.
But our source mentions that B-mode imaging alone had its limitations. What were some of the challenges there?
That's a crucial point. Early on, they realized that relying solely on that grayscale image had drawbacks.
Like what?
Well, getting clear images of deeper veins could be tricky.
Okay.
Plus, sometimes normal veins wouldn't compress properly under the ultrasound probe, which is a key diagnostic sign,
Right, checking if they collapse.
Exactly. And that could be due to factors like where the vein was located anatomically, or the patient's size, maybe obesity, or even if the area was tender or swollen.
So hard to press down properly.
Right. Edema or swelling could make it hard to apply enough pressure to really compress the veins and get a clear view. And visualizing the smaller veins in the calf, that was particularly challenging. So just seeing the picture wasn't always enough to tell the whole story.
Right, so seeing wasn't always believing. It sounds like they needed, more information.
Exactly. The real game changer came when they started combining the B-mode imaging, the anatomical picture, with the Doppler flow information.
The sound part.
Yeah, which tells you how the blood is actually moving. This combination, the duplex scan, provided a much, much more accurate assessment.
Really?
It allowed them to visualize veins that might have been unclear on grayscale alone, and crucially, to confirm whether blood was actually flowing normally.
Ah.
And within just a few years, duplex scanning became the primary the most reliable method for diagnosing these venous problems.
So merging structure and function.
Precisely. That's the key insight. They created a much more powerful diagnostic tool for you by combining those two elements.
That's a neat bit of medical history.
Yeah.
Really shows how technology evolves. So where are we now? It's not the 80s anymore. What's the focus today?
Yeah, the modern focus has really shifted. It's more towards optimizing the entire process.
How so?
Making it more efficient, improving the clarity and consistency of the reports,
Right.
and really reducing variations in how exams are performed and interpreted across different hospitals or clinics.
Standardization.
Exactly. Standardization. It's all designed to give you, the patient, a more consistent and reliable diagnostic experience.
And why is this standardization so important, for someone like me who might need this scan?
Because it helps ensure a certain level of quality and reliability no matter where you actually go for the test.
Okay.
And this is where organizations like the Intersocietal Accreditation Commission, or IAC, play a vital role.
IACs.
Yeah, they accredit facilities that perform vascular testing. You can think of this accreditation as a kind of mark of quality assurance.
Like a seal of approval. Tells you the vein scanning place meets certain standards.
Precisely. IAC accreditation signifies that the technologists doing the scans and the physicians interpreting them have the necessary training and credentials.
Okay.
It also means they're following established, consistent protocols for their examinations.
Right.
And this ultimately helps ensure that you receive a high-quality, dependable test.
That's really good to know. If a facility has that IAC accreditation, it definitely gives you more confidence in the results.
It should, yes.
Now, let's dig a little deeper into these standards and protocols. What are some key things that contribute to a, good quality exam?
Well, our source emphasizes that first and foremost, any venous duplex testing must be performed for appropriate, clearly documented medical reasons.
Right, there has to be a valid reason.
Absolutely. A valid clinical indication for the scan. You wouldn't just get one without a specific medical need.
That makes sense. It's not like a routine screening for everyone. What about the actual equipment they use? What kind of tech is needed?
Okay, the essential equipment includes a duplex ultrasound machine, and it has to have color flow Doppler capability.
Color flow.
Yeah, it shows the direction of blood flow using color. The machine also needs specific imaging and Doppler frequencies, appropriate for visualizing the particular veins being examined deep or superficial. And spectral Doppler is crucial too. This lets the operator precisely focus on the blood flow in a tiny area and measure its speed and direction accurately. Think of it like zooming in on the flow.
Okay.
And of course, the machine needs to clearly display and permanently record both the ultrasound images and those Doppler waveforms.
So definitely more sophisticated than a basic ultrasound machine. What about the process itself, the technique? Are there specific ways they need to do the scan?
Yes, technique is absolutely paramount. This includes proper patient positioning.
Like how you're positioned on the table.
Exactly. For example, when they're checking for reflux, that backward blood flow we mentioned, indicating leaky valves.
Yeah.
In the lower legs, the patient is often examined while standing, or maybe in a reverse Trendelenburg position.
Feet slightly lower than the head.
Correct. To help the veins fill with blood. Proper patient preparation, careful selection, and positioning of the ultrasound transducer, that probe they put on your skin. These are key steps too.
Okay.
The technologist needs to be really skilled at identifying the specific veins using both the grayscale image and the Doppler signals.
Right.
They also need to set the sample, volume size, and position correctly within the vein, optimize all the machine settings for the best possible images and flow info.
A lot to manage.
Definitely. And take accurate measurements of the vein's diameter. Importantly, this should be done with the limb in a dependent position, like hanging down, and without pressing on the vein because pressure can distort the measurement.
Okay, so the patient's position and the technologist's careful technique are really important for getting accurate results. What else is crucial during the scan?
They also use transverse grayscale imaging that's looking at the vein in cross-section, both with and without compressing the veins using the probe.
Right.
And when testing for reflux in the legs, they need specific maneuvers to encourage that backward flow so they can see if the valves are closing properly.
Like squeezing the leg.
Yes, manual compression applied below the area being scanned, or sometimes automated cuffs that inflate and rapidly deflate those, are now preferred over the Valsalva maneuver.
Holding your breath and bearing down thing.
Yeah. Especially for evaluating the common femoral vein and the saphenofemoral junction in the groin. The guidelines shifted because these other methods give more reliable, consistent results there.
Got it.
And finally, thorough, accurate documentation of everything they see is absolutely essential.
What kind of documentation?
Saving all the grayscale and color Doppler images, the Doppler waveforms, recording velocity measurements, vein diameters, the duration of any valve closure or reflux.
Wow.
Detailed descriptions of any abnormalities, waveforms at and just beyond any suspected blockages, and even a tracing showing where any superficial reflux starts and how long it lasts.
So really meticulous.
Absolutely. This detailed documentation lets the interpreting physician get a complete, accurate picture of your venous health.
Wow, it sounds like a very detailed and standardized process.
Yeah.
So after all that scanning and documenting, what does the medical professional look for to say, okay, your veins are healthy? What are the normal findings?
Right, let's talk about what they expect to see in normal, healthy veins. On the B mode image, the inside of a normal vein, the lumen, should look anechoic,
Anechoic,
meaning it looks black.
Mm-hmm.
Blood doesn't reflect ultrasound waves very well, so it appears dark, like a steel pond.
Okay.
However, the interface, the border between the blood and the vein wall, that will often appear echogenic or bright, especially if the ultrasound beam hits it at a good angle.
Right.
And the vein wall itself is typically thinner and more easily compressible than the wall of the artery right next to it.
Mm.
Interestingly, sometimes, especially if they're using a high-frequency transducer on a superficial vein,
Yeah.
they might actually see the flowing blood itself. This is more likely if the flow is a bit slower, causing red blood cells to clump together slightly in formations called rouleaux, makes them more visible.
So even healthy blood flow can sometimes be seen on the scan.
Yes, under the right conditions.
Mm.
Also, the size and shape of veins can vary quite a bit,
How so?
depending on things like how hydrated you are. If you're dehydrated, your veins might look more collapsed or oval, less fluid volume.
Makes sense.
Conversely, if the pressure in your veins is high, maybe due to heart failure or a blockage further up, they might look more distended, more swollen.
Okay.
And limb position, as we mentioned, plays a huge role. Elevate a limb, veins tend to collapse due to gravity helping drainage.
Right.
Let the limb hang down or be dependent, and the veins naturally fill up and dilate.
Gravity again.
Exactly, which is why, as we discussed, lower extremity exams are often done in that slight reverse Trendelenburg position. Helps the veins fill and makes them easier to see.
That makes perfect sense. Now, what about the actual blood flow? What does normal flow look and sound like on a duplex scan using the Doppler part?
Okay, this is where color flow Doppler and spectral waveform analysis come in. We use standardized terms to describe these waveforms,
Right.
focusing on the direction of blood flow towards or away from the probe, the pattern of the flow, and whether it's spontaneous.
Spontaneous meaning it's just there.
Yeah, present without any added pressure or movement. We also have modifiers like augmentation.
What's that?
That's an expected increase in flow when pressure is applied further down the limb.
Mm.
Then there's reflux, that abnormal backward flow we keep mentioning.
Right.
And specific patterns you might see with things like arteriovenous fistulas, which are abnormal connections between arteries and veins.
Yeah.
Now, in the arterial system, the heart's pumping action is the main driver. But in the lower pressure venous system, blood movement is greatly influenced by other things.
Like breathing.
Exactly. Most notably, respiration, your breathing. Normal venous flow is considered phasic with respiration.
Meaning it changes as you breathe.
Yes, the speed and even the direction of flow will change as you inhale and exhale. In the legs, flow typically decreases during inhalation and increases during exhalation.
Huh. Interesting.
And interestingly, in the arms, that pattern is often reversed. Also, the heart's rhythmic pumping has a more noticeable impact on flow patterns in the central veins, closer to the heart.
Though it's a really dynamic system, constantly responding to breathing and heartbeat.
Exactly. And under resting conditions, in a healthy vein, you should see spontaneous antegrade flow.
Antegrade, meaning the right direction.
Correct. Blood flowing in the correct direction, away from your feet or hands, towards the heart. But the speed of this flow will dramatically increase when your muscles contract.
Like when you walk.
Or even through manual compression by the examiner. These muscle contractions in your limbs act like a peripheral pump, squeezing blood through the veins.
Okay.
Now here's a key point. If there is a blockage in the vein, this expected increase in flow, this augmentation when you compress or move, it won't happen.
Ah.
This lack of augmentation is a really significant clue that something might be wrong, an obstruction.
Okay, so normal flow is spontaneous, changes with breathing, and increases with muscle movement. Now let's talk about when things aren't normal. What about DVT? Deep vein thrombosis. What are the key signs a professional looks for on a duplex scan that indicate a DVT?
Right. Well, the most direct and obvious sign is actually seeing the thrombus, the blood clot itself within the lumen of the vein on the ultrasound image.
You can actually see the clot.
Yes. If a deep vein has been newly blocked, it often appears distended, larger than usual, and maybe more rounded compared to the artery next to it.
Okay.
Over time, as the clot starts to organize, it tends to become more echogenic, brighter on the B mode image, easier to see.
And what about a fresh clot?
An acute or new thrombus might be firmly attached to the vein wall, or it could be more loosely attached, even mobile, sometimes described as a free-floating thrombus or having a visible thrombus tail.
So the clot itself becomes visible.
Yeah.
But you mentioned earlier that B-mode imaging alone has limitations for diagnosing DVT. Why is that important here?
Because a fresh thrombus, especially very early on, can sometimes be hypoatoic.
Darker.
Harder to see. Exactly. It might not be very bright on the ultrasound and could potentially be missed if you're only looking at the grayscale picture.
Okay.
Plus, the overall image quality can be affected by various things. Maybe the patient couldn't stay still, the vein is very deep, the machine settings weren't quite perfect.
Right.
In those situations, it can be challenging to confidently spot a thrombus just by looking at the vein's image. And that's why compression maneuvers are such a critical part of the exam for DVT.
You mean physically pressing on the vein with the ultrasound probe?
Exactly. In a normal vein, even with relatively gentle pressure from the probe, the vein walls will collapse completely. But if there's the thrombus inside, the vein either won't collapse at all or it will only partially collapse under pressure. It's important to note, though, that a very soft, recent, or non-occlusive thrombus one that doesn't fully block the vein might still deform a bit when compressed. And also, over time, as a vein that was blocked starts to reopen naturally, you might see some partial compressibility.
So that's why you can't rely just on the image or just on compression.
Precisely. That's exactly why we can't rely solely on B-mode imaging for DVT. We absolutely need the information from Doppler as well.
The flow information.
Right. The presence or absence of blood flow within the vein and how that flow responds to compression and other maneuvers gives us a much clearer, more reliable picture.
Okay.
Color flow Doppler is particularly helpful here. It shows whether a thrombus is completely blocking the vein or if there's still some blood flowing around it.
Helps visualize the blockage.
Yes, and it can also help identify those tricky, less visible anechoic thrombi by showing areas where there's no blood flow within the vein. And when looking for thrombus, especially one that might not be fully occluding, we typically use a lower color velocity scale on the Doppler. Makes us more sensitive to any slow flow that might still be present.
So it's the combination. Seeing the clot, checking compression, and assessing the blood flow with Doppler. That's what makes duplex ultrasound effective for DVT.
Precisely. In fact, it's so accurate that in the vast majority of cases, venous duplex ultrasound has now replaced contrast venography.
That's the one with the dye and x-rays.
Yeah, a more invasive procedure. Duplex is now the primary, often definitive test for diagnosing DVT.
Wow.
Numerous studies show that combining B-mode with both pulsed wave and color Doppler gives very high sensitivity for detecting clots in the larger proximal veins like thigh and pelvis, and also good specificity for ruling out DVT when no clot is present.
Okay.
Of course, the overall accuracy can be influenced by factors like how recently the study was done, the pretest probability, how likely the patient was to have a DVT beforehand, and whether the suspected clot is proximal or more distal, like in the calf.
That's a really significant shift in medical practice, moving away from that invasive procedure. What about telling the difference between normal variations in blood flow and an actual DVT? You mentioned that earlier.
Yes, it's crucial. For instance, those rouleau formations we talked about, the clumping of red blood cells, can sometimes look like echoes within the vein.
Right.
But a key difference is that these rouleaux typically break up and disappear when blood flow speeds up, either with augmentation maneuvers like squeezing the calf, or when the vein is gently compressed.
Oh.
A true thrombus, being a solid mass, will persist regardless of those changes.
It stays put.
Exactly. Also, while not seeing spontaneous blood flow might be normal in some smaller calf veins, it could also indicate a blockage further up.
Right.
So we rely on those augmentation maneuvers, squeezing the calf or foot to see if we can elicit blood flow. If we can't, that raises significant suspicion for an obstruction.
So it's about observing how the flow responds to different stimuli and pressures, not just what's initially visible. Now, let's talk specific locations. Our source mentions calf vein thrombosis. Is that different or harder to diagnose?
Calf vein thrombosis involving the smaller deep veins below the knee, like the peroneal and posterior tibial veins, is actually quite common.
Really?
Yes, and it often occurs in isolation without clots higher up. While duplex scanning can detect these, there are some nuances. For instance, you might not always detect spontaneous flow in these smaller veins at rest, but you should still see flow increase with augmentation compressing the foot or calf.
Okay.
Visualizing these smaller veins with B mode can also be tougher, especially in obese patients or those with significant leg swelling.
Right.
And that's where color Doppler becomes especially helpful. It can often confirm if the calf veins are open and flowing, even if the grayscale image isn't perfectly clear.
Now, I've heard that calf clots are sometimes seen as less dangerous than thigh clots. Is that generally true?
Generally speaking, yes. Isolated calf vein thrombi carry a lower immediate risk of causing a clinically significant pulmonary embolism, a clot traveling to the lungs.
Okay.
However, and this is really important, patients with calf DVT are still at risk for the clot extending or propagating up into the larger veins in the thigh and pelvis.
So it can move?
It can extend upwards, yes. Studies show that in maybe 15% to 20% of patients with symptomatic calf DVT, this proximal progression or recurrence happens within about 3 months. So while the immediate PE danger might be lower, a calf DVT still signals an increased overall clotting risk. Anticoagulation, blood thinners, might still be needed depending on the individual's situation.
Okay.
The risk of progression, or PE, is considered higher in certain cases, like if it's isolated to the calf, if it's a second VTE episode after recent orthopedic surgery with active cancer, or significant immobility.
So definitely not something to just ignore, even if it's only in the calf.
Yeah.
What's the typical approach if anticoagulation isn't started right away for an isolated calf DVT?
In those cases, careful serial follow-up duplex scanning is strongly recommended, usually over at least 2 weeks,
Watch it.
to monitor for any signs that the clot is extending into the larger veins above the knee.
Okay.
Our source also mentions thrombosis of the intramuscular veins within the calf muscles, the gastrocnemius and soleus veins.
Inside the muscle itself.
Yes. These can cause localized calf tenderness. They also have a relatively low PE risk if they stay isolated, but they should still be monitored with a follow-up scan, maybe a week later, to ensure they're resolving and not extending into the main deep veins.
Okay, so even within the calf, different clots, different risks. What about clots higher up, in the iliac veins in the pelvis? Or the inferior vena cava, that big vein returning blood to the heart? Are those harder to see?
You are absolutely right. The iliac veins and the IVC can be quite challenging to evaluate well with standard ultrasound.
Why is that?
They're deeper inside the abdomen and pelvis, and overlying bowel gas frequently interferes significantly with the image clarity.
Ah, the gas problem.
Exactly. So just using B-mode imaging and trying to compress those vessels from the surface, often not very effective there.
So what do?
Ideally, to minimize bowel gas, patients should try to fast for about 6 hours before an ultrasound of these central veins.
Okay.
And in these cases, we rely much more heavily on Doppler, both pulsed wave and color Doppler, to assess the blood flow patterns.
Listening becomes even more critical when seeing is hard.
Precisely. Normal flow in the IVC should be spontaneous and phasic, with respiration changing as you breathe. A complete absence of detectable flow. That's a strong indicator the IVC might be occluded by thrombus.
And the iliac veins.
For the external and common iliacs, we sometimes get flow augmentation by compressing the thigh below where we're imaging. We also look for where the internal iliac joins the external.
Okay.
A lack of color Doppler signal in these iliacs might suggest thrombus. Similarly, if we don't see spontaneous flow or the normal changes with breathing, if the flow seems continuous instead, that could point to more central blockage higher up in the iliacs or IVC.
Continuous flow is bad.
It suggests something is blocking the normal phasic changes further upstream. We also often compare flow patterns between the two legs.
How does that help?
It can give indirect signs. For example, continuous flow in one common femoral vein, but normal phasic flow in the other. That might suggest an iliac obstruction on the side with the continuous flow.
Ah, clever.
We might also see elevated blood flow velocities if there's a narrowing, a stenosis. And it's worth remembering, abnormal flow patterns in the leg veins can sometimes reflect issues higher up in the cardiovascular system, like heart failure or problems with heart valves like tricuspid regurgitation.
It really is amazing how interconnected the whole circulatory system is. We've talked a lot about leg DVT. What about the arms? Is upper extremity DVT a similar concern, and how is duplex used there?
Upper extremity DVT is definitely a concern, though less common than in the legs.
Okay.
It often develops due to a known factor like central venous catheter.
For meds or dialysis.
Exactly, or pacemaker wires or underlying cancer. But primary upper extremity DVT can also happen.
Without those factors.
Yes, most often due to compression of these subclavian and axillary veins as they pass through the thoracic outlet, that narrow space between the collarbone and first rib, often called Paget-Schrader syndrome.
Okay. And diagnosis. Is it still ultrasound?
While catheter venography, the dye test, can be used, especially as part of treatment sometimes, duplex scanning is generally considered the primary preferred first-line diagnostic tool for suspected upper extremity DVT.
The ultrasound sign's the same as in the legs, looking for clots?
There are definitely similarities. For example, the inability to fully compress a vein is still a key sign of thrombus.
But can you compress veins in the chest easily?
Not really. Compressing veins in the central chest isn't practical because of the bones and tissues.
Right.
So while Doppler flow assessment is still critical to check patency, the central anatomy limits how much of the proximal veins like brachiocephalic veins, superior vena cava, can be directly seen with B mode.
Okay.
We do typically expect to see more pulsatility, more variation with the heartbeat in veins closer to the heart and in the upper arm.
Right.
A noticeable difference, asymmetry, in Doppler waveforms between the two arms might suggest a central blockage, but collateral veins, those alternative pathways that form to bypass a blockage, can sometimes limit how sensitive these indirect findings are.
Okay.
But despite these challenges, reviews of studies show that upper extremity venous ultrasound is generally quite sensitive and specific for diagnosing DVT there.
So, same principles, but adapted for the different anatomy and limitations in the upper body. Now, let's shift focus a bit to limited or point-of-care ultrasound, POCUS. How does that fit in with DVT diagnosis?
Point-of-care ultrasound, PSCOS, yeah. It's become increasingly valuable. We have smaller, more affordable, user-friendly ultrasound systems now.
Right. Portable ones.
Exactly. So it's used in lots of settings, clinics, ERs, hospital wards, for a quick initial assessment for things like DVT.
Quick assessment. How accurate is it?
Well, with proper training and protocols, it seems healthcare providers using POCS can achieve accuracy for DVT in the femoral and popliteal veins that approaches the standards of dedicated vascular labs.
That sounds really useful for getting fast answers. How does it typically work? What do they look at?
There are a couple of common techniques. One is the two-point compression ultrasound.
2 points.
Focuses just on the common femoral vein in the groin and the popliteal vein behind the knee, checking compressibility there.
Okay, and the other?
The three-point technique expands on that. It adds assessment of the common femoral vein where the saphenous vein joins and the proximal, superficial, and deep femoral veins in the upper thigh.
So still limited compared to a full scan.
Yes, definitely. These limited exams might not be as sensitive as a comprehensive vascular lab study because they don't evaluate the whole venous system in the leg.
Right.
But they can be particularly useful for quickly evaluating ambulatory patients, people walking around who have a lower suspicion for DVT and can get follow-up testing if needed.
But maybe not ideal for everyone.
Possibly. In higher risk patients, like critically ill people in the hospital, the potentially lower sensitivity of a limited POCUS exam might be more of a concern.
Makes sense.
Research shows that in the ER setting, PCUS by trained physicians can have high sensitivity and specificity for DVT, but, the overall accuracy depends on factors like the patient population, the pretest probability, and the experience of the person doing the scan.
So a variable tool for rapid initial assessment, especially in lower risk situations, but maybe not a complete replacement for a full vascular lab exam in all cases.
Exactly. And it's also worth noting, in most dedicated vascular labs, routine scanning of both legs isn't standard practice.
Oh, why not?
Unless the patient has symptoms in both legs, or there's another specific reason to suspect clots in both, like a known clotting disorder, systemic symptoms, or suspicion of a PE.
Oh.
Unilateral studies, just focusing on the symptomatic leg, are much more common if symptoms are only in one limb.
Okay, that makes sense. Target the exam to the concern. Now, our source also discusses determining the age of a thrombus found on ultrasound. Why is it important to try and estimate how old a clot is, and can ultrasound really tell us that?
Yeah, determining the age can be clinically significant. The potential for a clot to cause serious complications, like a PE, typically changes over time.
How so?
A new or acute thrombus generally carries the highest risk of breaking off and traveling to the lungs. As a thrombus ages, it tends to become more firmly attached, more organized, and less likely to embolize.
Okay.
And the estimated age can sometimes influence treatment decisions. So reputable vascular labs should have criteria to report the appearance and characteristics of any thrombus they find, giving an estimate of its relative age.
So ultrasound gives clues about whether a clot is fresh or older. What are some of those clues?
Well, Table 25.3 in our source summarizes typical features. An acute early thrombus often looks relatively hypoechoic darker.
Right.
It might show some mobility or be loosely attached. The vein itself might look enlarged, distended. The vein wall is usually thin and smooth.
And compression.
It might be somewhat deformable, spongy. It may or may not completely block flow. With color Doppler, you might see no flow or an abnormal pattern with gaps where the clot is. And typically no collateral veins yet. Valves are usually okay at this stage.
And how does an older, more established clot look different?
A late oldal thrombus tends to be more echogenic, brighter. The vein lumen might actually be smaller than the artery next to it, maybe irregular shaped.
Okay.
The vein wall might look thickened and also brighter. The thrombus itself will likely be more rigid, incompressible, though you might start seeing signs of recanalization.
Recanalization,
Yeah.
the body trying to reopen.
Exactly, creating channels through the clot. With Doppler, you might see varying degrees of flow returning, and it's common to see collateral veins that have formed to bypass the blockage.
And the valves?
The valves in a vein with a chronic thrombus are often incompetent, leading to reflux, that backward flow.
So it's really a combination of visual and flow characteristics that helps estimate the age.
Exactly. We talk about the sonographic evolution of a thrombus.
Yeah.
From that softer, darker, maybe mobile acute stage to a firmer, brighter, more organized, older stage, more stuck to the wall.
Okay.
Over time, it might even undergo lysis dissolve and the vein might recanalize. But how much it resolves varies a lot between patients.
Right.
And it's important to clarify terminology. Acute just means a new thrombosis. The term chronic venous thrombosis can be problematic.
Why?
Because what we often see months or years later isn't necessarily active clot, but residual stuff, often fibrotic scar tissue left in the vein. So the preferred term is chronic post-thrombotic change. And the key point is, just seeing these chronic changes doesn't automatically mean you need ongoing anticoagulation unless there's evidence of a new acute clot.
Got it.
The term subacute is also pretty nonspecific and generally not recommended. There aren't really verified ultrasound criteria to precisely age a thrombus in weeks or months.
So you can't say this clot is exactly 6 weeks old.
No, not reliably. So if the findings aren't clearly acute or chronic, the preferred description is venous thrombosis, indeterminate age.
Okay.
Ultimately, treatment decisions always consider the individual patient's circumstances and risk factors. An incidental DVT found in someone without symptoms might warrant considering anticoagulation, but the evidence is a bit limited. Clinical assessment is crucial.
That clarity in terms and understanding the limits of dating clots seems really important for good patient care. Now, our source also mentions some novel ultrasound techniques, specifically elastography. What is that, and how might it relate to veins?
Elastography, yeah, it's an interesting evolving ultrasound technique. It lets us assess the mechanical properties of tissues, specifically their stiffness or hardness.
Stiffness, like how firm something is.
Exactly. It measures how much a tissue deforms when a force is applied, gives information similar to what a doctor feels with palpation, but more objective, quantifiable.
Okay. Where is it used now?
Its main clinical uses have been in areas like measuring liver stiffness and fibrosis or evaluating breast masses, but it's being researched as a potential tool for better characterizing the age and chronicity of venous thrombi.
So using ultrasound to essentially feel how stiff or soft a blood clot is.
Precisely. There are a few different types. Compression elastography, or strain imaging, compares how much tissue deforms with and without slight probe compression. Harder tissues, like older clots, deform less.
Okay.
Acoustic radiation force impulse, ARFI, uses the ultrasound beam itself to create a tiny push inside the tissue, causing microscopic movement. Analyzing the response gives a qualitative stiffness measure, mostly used for liver, but studied for thrombus too.
Interesting.
Then there are more advanced techniques like shear wave elasticity imaging, SWEI, and shear wave induced resonance elastography, SWIRE. These use special shear wave to assess elasticity quantitatively, giving actual numbers for stiffness.
So more precise measurements.
Potentially, yes. Feasibility studies show potential for using these shear wave techniques to assess thrombus elasticity.
But is it standard practice yet?
No. It's important to understand that right now, Elastography for thrombus characterization is still largely in the research and development phase. It hasn't been standardized or widely validated for routine clinical use in most vascular labs.
Okay, so something to watch for in the future, perhaps. Now let's move on to what happens after a DVT diagnosis. How does venous ultrasound play a role in deciding how long someone needs anticoagulation blood thinners?
Right. When deciding on the duration of anticoagulation for a first unprovoked VTE, meaning no obvious cause, like surgery,
Yeah.
physicians have to weigh the benefits of preventing another clot against the risks of long-term blood thinner use, like bleeding.
A balancing act.
Definitely. Several factors come into play. Are there ongoing provoking risks? Was it truly unprovoked? Does the patient have active cancer, which is a big risk factor for recurrence?
Okay.
The risk of recurrence is generally lower if there was a clear reversible risk factor initially, like recent surgery. And as we discussed, isolated CAF DVT also carries a somewhat lower recurrence risk compared to proximal DVT or PE.
Higher risk.
Higher risk if it's a second or subsequent VTE event.
So it's very individualized. Does follow-up ultrasound information help refine that decision?
It certainly can. One thing we look for on follow-up scans after DVT treatment is residual vein thrombosis, or RVT.
Meaning leftover clot.
Exactly. Is there still some clot remaining after anticoagulation? The DECUS study, for example, found that in patients with the first proximal DVT, having residual thrombus in those proximal veins on follow-up was linked to an increased risk of recurrence.
And if it was gone?
Conversely, patients where the thrombus completely resolved, no RVT, had a very low risk of recurrence.
Interesting.
Extending treatment to 2 years did reduce recurrence risk in those with a persistent RVT, but it didn't eliminate it entirely.
What about cancer patients?
Another study, Cancer DECUS, looks specifically at cancer-associated VTE. It found that while absence of RVT after 6 months identified a lower risk subgroup, it wasn't low enough to change general guidelines, which often recommend long-term anticoagulation for cancer patients with VTE history.
Okay. Anything else besides ultrasound findings?
Yes, the D-dimer level, that blood test for clot breakdown products, has also been looked at. Some studies show higher D-dimer levels after stopping anticoagulation are linked to a greater chance of another VTE.
So another data point.
Right. The PROLONG study suggested an elevated D-dimer a month after stopping anticoagulation seemed to be a risk factor for recurrence, whereas RVT at the time of stopping wasn't a significant predictor in that specific study.
So the evidence is still evolving.
It is. The role of RVT and D-dimer in guiding anticoagulation duration continues to be studied, but they can provide valuable extra information to help doctors tailor the treatment plan to an individual patient's risk profile.
So following ultrasounds for residual clot, plus blood tests like D-dimer, give doctors more data for those complex decisions about treatment duration. Now, what about diagnosing a recurrent thrombosis? If someone's had a DVT before, how do you know if they've got a new one?
Diagnosing recurrent VTE can be really challenging in patients with a prior DVT history.
Why is that?
Well, having had a DVT before is itself a big risk factor for another one, especially if the first one wasn't clearly linked to a temporary cause or the underlying cause wasn't found.
Okay.
Plus, a previous DVT often leads to long-term damage to the veins and valves, causing persistent symptoms, chronic leg pain, swelling, heaviness that can last for months or years.
Post-thrombotic syndrome.
Exactly. So if someone with a DVT history comes in for a new ultrasound because their symptoms are back or worse,
Yeah.
any abnormal findings might actually be residual damage, chronic post-thrombotic changes from the old clot, not a new acute one.
So it's hard to tell if it's the old problem or a new one.
Exactly. Residual non-compressible vein segments or other post-thrombotic abnormalities can be found in a very high percentage of patients months after their first DVT.
So distinguishing is crucial.
Absolutely crucial, because post-thrombotic syndrome isn't typically treated with anticoagulation unless there's a confirmed new clot. Sometimes ultrasound might show venous reflux, leaky valves, explaining the chronic symptom. However, it's also possible to get a new acute thrombus in a vein segment that was already abnormal from old disease, an acute on chronic DVT.
Right.
Or to get a totally new DVT in a vein segment that looked normal before.
So how do they tell?
If the ultrasound shows findings classic for an acute thrombus, like a newly non-compressible segment in a previously normal vein, alongside chronic changes elsewhere, that strongly suggests recurrence.
But one scan might not be enough.
Often, yes. A single scan at the time of suspected recurrence might be insufficient. The most reliable way to know if a new DVT occurred is to compare the current scan with previous venous duplex studies the patient has had.
Comparison is key.
Absolutely. Ideally, a baseline scan done after the first DVT treatment is finished establishes a new baseline showing what residual changes were left.
Got it.
Then, if a later scan shows new abnormalities compared to that baseline, it's much clearer if a new event likely happened.
Makes sense.
And remember, veins can change over time. Late recanalization, reopening, can happen even 9–12 months after the initial DVT, so findings aren't always static.
So keeping copies of prior ultrasound reports is really important for patients and doctors. What if a prior study isn't available?
Yeah, that makes it tougher. In that situation, the physician has to rely on the patient's current clinical presentation, relevant lab findings like D-dimer, and the current ultrasound findings all considered together.
Okay.
Recurrence is generally more likely if there are new or persistent risk factors. A normal D-dimer can be helpful, suggests findings are more likely chronic, but an elevated D-dimer is less specific. It can be raised for many reasons.
Okay, so a more complex assessment without that prior study comparison.
Yeah.
Now let's shift to superficial veins. When does venous duplex scanning specifically focus on these veins closer to the skin surface?
Right. Patients might initially be referred for a scan suspecting DVT, but we also need to consider disorders of the superficial veins. During a standard lower leg DVT exam, the great saphenous vein, especially where it joins the deep system in the groin, the saphenofemoral junction, is usually visualized briefly.
Right.
But a more comprehensive, thorough evaluation of superficial veins is typically indicated if the patient reports specific symptoms.
Like what?
Localized pain, swelling, redness along a superficial vein, a palpable firm cord under the skin, or painful varicose veins.
Okay.
Also, ultrasound is used to map out superficial veins if they're being considered for use as bypass conduits in vascular surgery.
So not just ruling out DVT, superficial veins themselves are important and scanned. What kinds of issues affect them?
The general term for a clot in a superficial vein is superficial venous thrombosis, or SVT.
SVT.
You might also hear superficial thrombophlebitis, which implies inflammation is present pain, tenderness, warmth, redness. Inflammation is actually more common with SVT than DVT.
Okay.
In severe cases, if there's bacterial infection in the clotted superficial vein, it's called suppurative thrombophlebitis.
Got it. What causes SVT?
Lower leg SVT is frequently associated with varicose veins, but importantly, if SVT occurs in someone without varicose veins, it might indicate an underlying issue.
Like?
A hypercoagulable condition, increased clotting tendency, or maybe undiagnosed cancer, vasculitis, vessel inflammation, or other systemic diseases. There's even Trousseau sign recurrent migratory superficial clots in unusual places, sometimes linked to adenocarcinoma. Both inherited and acquired thrombophilias increase risk for SVT and DVT, and for SVT progressing deeper.
Okay. And in the arms.
Upper extremity SVT is often a complication of medical things like IV catheters or blood draws.
Okay, so even though it's superficial, it can be linked to other conditions. How is SVT diagnosed with ultrasound? Is it similar to DVT?
Yes, the ultrasound findings are quite similar to DVT. The affected superficial vein looks distended, it's incompressible, there's echogenic material, the thrombus inside. Often, no detectable blood flow with Doppler in the clotted segment. If there's inflammation, we might also see vein wall thickening, swelling around the vein, perivascular edema, and tenderness with the probe.
Got it. And what's important when SVT is found?
It's particularly important to determine the extent of the thrombosis, how far it goes.
Why?
Because of the risk of it propagating further along the superficial system or, more concerningly, extending into the deep system, especially at junctions like the saphenofemoral junction in the groin.
Ah, the connection point.
Exactly. The proximity to these deep connections can influence treatment. Anticoagulation might be considered in high-risk cases to reduce the risk of extension or recurrence.
Does it often extend?
Studies show DVT can develop as a complication in around 11% of untreated SVT cases, often via that saphenofemoral junction. This has led to recommendations for anticoagulation or close monitoring with serial ultrasounds for clots in the proximal great saphenous vein. Other research showed thromboembolic complications, DVT-TE, in about 10% of symptomatic lower leg SVT patients, even with anticoagulation in many. Risk factors for complications included male sex, prior VTE, cancer, and no underlying varicose veins.
Interesting. So superficial vein evaluation is also part of chronic venous insufficiency exams.
Yes, it's an integral part. We assess the main axial superficial veins and their tributaries for patency, diameter, and their anatomical course. Because superficial vein anatomy varies so much, diagrams and detailed notes are really helpful, especially for planning varicose vein treatments. Duplex mapping is often needed before those procedures to precisely define which segments are refluxing.
That highlights how important superficial veins are, too. You mentioned vein mapping a couple of times. What exactly is involved in that?
Preoperative vein mapping with ultrasound is crucial for checking the suitability of superficial veins for two main purposes.
Okay, what are they?
First, and probably most common, is for creating an arteriovenous fistula, or AVF.
For dialysis.
Exactly. That surgically created connection between an artery and vein, usually in the arm, for hemodialysis access in kidney failure patients. An AVF is generally the preferred long-term option.
And ultrasound helps with that.
Definitely. Routine preoperative ultrasound mapping significantly improves AVF outcomes, better patency, better successful use for dialysis. It helps the surgeon pick the best vein segment and the right procedure type. Studies show using ultrasound mapping plus physical exam leads to fewer immediate surgical failures and better fistula maturation.
So a detailed pre-op assessment to ensure good quality veins for the dialysis access.
Exactly. National Kidney Foundation guidelines recommend trying distal upper extremity ADFs first. They generally look for arm veins bigger than 2.5 millimeters for AVF creation, though sometimes smaller ones might work.
Okay. And the second purpose for vein mapping?
To assess superficial veins, especially the saphenous veins in the legs, for use as bypass conduits in revascularization procedures.
For blocked arteries in the legs.
Right. Restoring blood flow often due to peripheral artery disease. Preoperative vein mapping helps reduce costs and improve outcomes for infrainguinal bypass surgery, bypass below the groin. It can also help surgeons decide between endovascular, catheter-based, or open surgery for critical limb ischemia.
So it helps pick the best vein and guides the overall surgical strategy.
Precisely. When doing lower extremity vein mapping, the patient's usually in reverse Trendelenburg to help veins dilate. A high-frequency transducer is used to image the whole great saphenous vein, maybe the small saphenous too.
What do they measure?
Diameter is measured carefully all along its course. The tech notes any anomalies like accessory veins or big branches, and assesses the vein for prior thrombosis or phlebitis.
How?
Checking compressibility, looking for wall thickening, echoes inside suggesting old clot or hardened valves. Sometimes they even mark the vein's course on the skin to guide the surgeon.
And for the arms?
For upper extremity mapping, a tourniquet is often used to dilate the veins, maybe in the armpit for upper arm, elbow crease for forearm. Then they measure the diameters of the brachial, cephalic, and basilic veins.
It sounds like creating a very detailed roadmap of the superficial veins before surgery.
Yeah.
Now let's move to evaluating chronic venous disease, specifically venous insufficiency. How is duplex scanning integral here?
The vascular lab, with duplex scanning, plays a truly integral role in evaluating chronic venous insufficiency, CVI.
Okay.
There's the CAP system, clinical etiology, anatomy, pathophysiology, a standardized way to classify and report chronic venous disease.
Right.
Diagnostic assessments are often tiered. Level 1 is like a basic office visit with a handheld Doppler. Level 2 is the non-invasive vascular lab duplex scanning, maybe plethysmography. Level 3 involves more invasive or complex imaging.
And duplex is level 2.
Yes, and it's invaluable because it lets us objectively evaluate both the vein anatomy and the underlying pathophysiology, the abnormal flow patterns causing symptoms.
So while DVT diagnosis is about finding clots blocking flow, CVI evaluation is more about leaky valves and the direction of flow over time.
That's a very accurate way to put it. Acute DVT symptoms, swelling, pain are mainly from the obstruction, but CVI develops from sustained high pressure in the lower leg veins.
What causes that high pressure?
Several things. Persistent outflow obstruction after a DVT, abnormal backward blood flow due to incompetent leaky valves, venous reflux, or often a combination of both.
Okay.
Sometimes chronic narrowing or blockage of deep veins can also cause ongoing symptoms like venous claudication, leg pain worsening with exercise.
But leaky valves are most common.
By far. Valvular incompetence is the most common CVI cause. It can be primary, inherently weak valves, or secondary, damaged by prior DVT or injury.
Right.
Competent valves plus the calf muscle pump are essential for efficient one-way flow upwards when we're upright. If valves are incompetent, the pump is less effective, leading to persistently high venous pressure when standing or walking, ambulatory venous hypertension.
So when evaluating CVI with duplex, you're looking for blockages. And, importantly, those leaky valves causing backward flow. How does the scan show that?
Exactly. For CVI, Duplex directly assesses obstruction appearance, compressibility, flow patterns with maneuvers. It also gives indirect signs of central obstruction flow asymmetry between legs, lack of normal breathing changes, no spontaneous flow are expected.
Okay.
We typically use a 4.7 MHz linear transducer, maybe lower frequency curved for larger patients, higher frequency for very superficial veins. And crucially, for reflux testing, the patient must be upright, standing,
Why standing?
to put the veins under hydrostatic pressure, making reflux more obvious. Often they'll rotate the leg out, put weight on the other leg, or use a step.
Okay. Can you see the valves themselves?
Sometimes on B mode, but we primarily assess function by observing flow direction with Doppler. When standing, valves should open for flow towards the heart, then close promptly when flow reverses due to gravity.
And when they don't close properly, that's reflux, the hallmark of insufficiency.
Precisely. Venous reflux is retrograde, backward flow, lasting an abnormally long time. It can be axial, groin to calf, segmental, only some segments leaky, or in perforators, outward, deep to superficial.
How do you make the reflux happen during the test?
We use provocative maneuvers. Valsalva can be used for the groin area, more commonly manual compression below the scan site, then rapid release.
Right.
But the preferred, most standardized technique for lower leg reflex testing while standing uses calibrated pneumatic cuffs.
The inflatable cuffs.
Yes. Inflated around the calf or thigh, then rapidly deflated. This sudden release initiates significant backward flow, reliably testing if valves close properly and for how long.
And testing lying down isn't good enough.
No. Supine testing isn't physiologically relevant. It doesn't simulate gravity's effect and can lead to errors. Even modest reverse Trendelenburg is less consistent than true upright standing for accurate reflux assessment.
And how long does backward flow have to last to be abnormal, to indicate insufficiency?
Studies suggest various cutoffs. Maybe 1.0 second in femoral popliteal veins, 0.5 seconds in superficial calf deep veins, 350 milliseconds outward flow in perforators.
Any consensus?
A more recent multi-center study suggested 0.5 seconds might be a good threshold for all axial veins in the lower leg. Vascular labs should document their criteria.
Okay. And the report needs details.
Essential to include the measured reflux time for each segment, patient position, explaining if not standing, and the maneuver used to elicit reflux.
So standardized testing standing, calibrated cuffs is key for reliable CVI info. Now, you mentioned perforating veins briefly. What's their role in chronic venous disease, and how are they checked?
Perforating veins, they connect the superficial and deep systems, passing through the deep fascia, that tissue layer separating muscle from subcutaneous fat.
Okay.
Normally, blood flows superficial to deep through them. Larger ones, 1 millimeter, have valves ensuring one-way flow. Smaller ones often don't.
How are they scanned?
Best done in transverse plane, looking where they penetrate the fascia. Flow can be bidirectional sometimes, but reflex is defined as net outward flow, deep to superficial, lasting an abnormal time.
Are they always checked?
Maybe selectively. In advanced CVI, non-healing ulcers, or recurrent varicose veins after treatment,
Is treating them always needed?
there's some debate. But guidelines suggest treatment might help for pathologic perforators, those under an ulcer, reflexing 350-500 meters, and diameter 3.5 millimeter. Diameter 3.5 millimeter often correlates with reflex.
Okay. And texts document this carefully.
Yes, often using detailed notes and anatomical drawings. These visual aids are really useful for planning CVI treatments, showing incompetent axial veins, tributaries, and reflexing perforators.
It sounds like creating a comprehensive map of the whole system, deep, superficial perforators, is crucial for managing CVI effectively.
Absolutely. And our source even includes a helpful algorithm for how a lab might approach a DVT scan, considering if it's initial versus follow-up, outpatient versus inpatient, one leg versus both, helps guide the exam appropriately.
That's a really useful overview of how all these aspects of venous duplex scanning come together clinically. And the chapter also lists key references for deeper dives.
Yes, it points to important textbooks, clinical practice guidelines from groups like the American Venous Forum and AIUM, plus the IAC accreditation standards, all great resources for more detail.
Where this has been a truly deep dive into venous duplex scanning. We've covered its principles, history, the importance of standardization and interpretation, its vital role in diagnosing DVT and CVI, and even applications like vein mapping. It's clear this non-invasive imaging is absolutely essential in vascular medicine.
Indeed. And we certainly hope that you, our listener, now have a much clearer, more comprehensive understanding of what's involved in this common and very important medical imaging procedure.
Finally, let's leave you with a thought. Given how fast technology advances, especially in ultrasound and imaging, how might our ability to understand, diagnose, and manage venous diseases transform further in the future? What new possibilities might emerge?
That's a truly fascinating question to ponder. The future of vascular diagnostics is exciting. And if this deep dive sparked more questions or areas you'd like to explore further, we certainly encourage you to do that.